Above the clavicular, right. Right side.
Put your...
Well, she tried to point that there.
Okay.
Just put one.
Yes, if you want, you can here. If you want, you can just point the auscultation point on the left side comparatively.
It's not balanced.
No, you're supposed to ask the patient to breathe.
Yes.
That's very important. That's very good. So normally we are trying to find the normal breathing auscultation, because if you ask the forced auscultation, you would find a little bit different sound. Do you remember? When the person is doing deep breathe in and deep breathe out, what would be? Would be like increased, would be increased vesicular sound, right?
Yes.
But you want to find the normal sound. So that's why you firstly ask the patient to do the normal breathing. And when you do that, especially the auscultation of the bottom side, try to do that, the bottom side. So try to go systematically, starting from the upper part. Yes. Left or right, left. Exactly. And the same as we do for percussion. Over here already, heart area. So, in English variants, they still compare. But for me, this is no need, because you have to change your mind from lungs auscultation into heart auscultation. So there is no really practical need. That's why, for me, the Russian variant is much better, not because I'm Russian doctor, but because you're still focused on lungs auscultation. So right, left, right, left, right, right.
Right.
The same as you do for percussion. Yes, and now right. You don't have to auscultate each intercostal space as you do for percussion. The areas would be above, below, and then you do right and right and right. So that's enough. You don't have to do once again the whole all the intercostal spaces. If you found something abnormal, then you do all intercostal spaces and through the whole intercostal space from the front side to the left to the back side.
And like, what could be the abnormal thing we could find? Let's say, for instance, the person has like hyperthorax or maybe like some fluid in the airway.
Sure.
Breaths.
So let's firstly try to auscultate him normally.
Lungs.
So put your stethoscope into your ears. Press it firmly. Because you have to press the stethoscope firmly, because you have some air between the stethoscope surface and the skin surface. It must be very firmly, yes, like this. So, now, right now, put the stethoscope, and you have to synchronize with the patient breathing. So you look at him, how he is breathing in. And at the same moment, you try to find out what do you hear in the stethoscope. Then you see how he is breathing out. And you try to find out what do you hear at this moment in the stethoscope. Try to do that.
Question. I think, is it possible that we have to explain to the patient the difference, like how to breathe thoracically, not diaphragm, using diaphragm, but using your chest? Is it important?
No, that's
No.
normal.
No.
So they just
Because they would try to do somehow, and they would be, it won't be comfortable for them, and it won't be, the proper English word, it won't be physical for them.
Okay.
And you first want to find out exactly their breathing. So if you try to. So you look at him while he breathe in. Do you see how he's breathing? Yes, you can. Yes, you can see. So now put your stethoscope. Does everyone else Anybody else has stethoscope?
Yes.
Take a stethoscope.